Dr. Andy Lee is up again, and he's going to talk to us about childhood optic neuritis.
So I'm pitch hitting for Mike. A lot of what I'm going to tell you has already been touched on a little bit by the previous talks, so it'll be a good review. I want to describe for you the key differences between childhood and adult optic neuropathies, and especially optic neuritis in this talk, and list for you the different approaches to diagnosis and treatment that are driven in children versus adult patients, and tell you that there is a very limited evidence base in childhood optic neuritis as opposed to the optic neuritis treatment trial and the longitudinal optic neuritis study, which has given us very good longitudinal data. We don't have the same study for children. And then I'll tell you my approach, but as a clinician, you're going to have to individualize the evaluation for each child that you see because it's quite different every patient. So childhood optic neuritis looks and acts a little bit differently than adult optic neuritis. And this is a paper from Neurology describing the clinical features, the MR findings, and the outcome of optic neuritis in children. This study had 36 children with a female to male ratio of 1.6 to 1. Their ages ranged from 2.2 years to 17.8 years, and as Pam alluded to, the mean for childhood optic neuritis is 12 years, okay? But in my experience, the closer you are to being an adult, i.e. 16, 17, 18, the more likely it's going to represent regular adult optic neuritis. So the older the child is, the more likely I'm going to extrapolate the results of the optic neuritis treatment trial to that patient. The younger the patient is, the less comfortable I am applying the results of the ONTT to children. You can see one of the striking differences right away, 58% unilateral, but 42% bilateral. So as Peter mentioned to you, unilateral optic neuritis is the typical adult optic neuritis, and bilateral normally prompts more aggressive evaluation in an adult. But in a child, it's kind of a relatively common finding. Severe vision loss, now perhaps that's ascertainment bias because an adult patient is going to come in at 20/40 because they can't read or they can't do their job, but a kid might let a 20/40 optic neuritis pass. And so even though there's clearly worse vision in childhood optic neuritis, that may be just because we only see the kids that are blind and we don't see the 20/40 optic neuritis in a 7-year-old who's not even complaining about anything. Full recovery in the majority of the patients, 83%, but not as good as the adult patients, and that's because of what Pam told you about, which is acute disseminated encephalomyelitis. The mirror imaging studies in this cohort, brain MR, showed white matter lesions in 54% of the cases. Now you remember from the optic neuritis treatment trial that we use that for prognosticating for MS in adults. But in children, because of this acute disseminated encephalomyelitis, it could still be a monophasic illness. And so the presence of these white matter lesions does not mean it's multiple sclerosis in a kid, although it could be because of ADEM, acute disseminated encephalomyelitis. What's interesting in this study that had a follow-up of 2.4 years with this range, 36% of the cohort developed multiple sclerosis. And one of the patients had the Divec disease. So in my practice, if they have bilateral optic neuropathy and have spine symptoms, we're going to do the NMO antibody that Pam alluded to, and we're going to tell the patient's family that even though the chance of multiple sclerosis is less because they're a child, it is not zero, okay? It is not zero. There is such a thing as childhood multiple sclerosis. And what was fascinating about this study is bilateral optic neuropathy. The thing that Peter and I just told you was not typical for multiple sclerosis is more likely, in this study at least, to develop MS. All these children had white matter lesions on their brain MR, and no child who had a normal brain MR at onset developed multiple sclerosis, at least with this short follow-up. So as opposed to all the stuff we told you about adult optic neuritis, childhood optic neuritis looks and acts differently than adult optic neuritis. And so if we just had to summarize the differences in one slide, you have adult, the typical case Peter Savino described to you, unilateral. Most of the time, the patient sees nothing, the doctor sees nothing. It's retrobulbar. And even when there is swelling, it's not that much. Pain on eye movement, usually we reserve that term for demyelinating optic neuropathy, idiopathic or associated with MS. And MS is common, especially if you have white matter lesions. And if it's bilateral, we're going to be thinking about neuromyelitis optica. In kids, kids, the bilateral is very common, way more common than in the adult form. Most of the patients have a swollen disc as opposed to retrobulbar. They have pain, but usually it's headache in addition to pain on eye movement, and as Pam alluded to, ADEM, post-infectious and post-vaccine, as well as isolated optic neuritis occurs after infectious disease, usually viral or post-vaccine. And the risk of MS is lower, but it is not zero, and in some series is as high as a third. The older they are, the more likely they are to resemble typical optic neuritis and MS risk factors in adult. And the key thing that you should have taken away from Pam's talk is you need to be thinking about acute disseminated encephalomyelitis, ADEM, in childhood bilateral optic neuritis. And the disc swelling can be bad, as opposed to what Peter told you, which is when we see this kind of disc swelling this bad, we're thinking about non-demyelinating optic neuritis. That's true in adults, but in children, papillitis is the rule, not the exception, and it can be severe. Now, part of that's because their CSF is full of cells if they have ADEM, and some of those patients, at least in my practice, have had elevated intracranial pressure, probably because their cells and their CSF protein are elevated. So, the evaluation is a little bit different. This is not evidence-based because we have no equivalent ONTT in childhood. But in the ONTT, the optic neuritis treatment trial in adults, typical optic neuritis, no lumbar puncture, no labs. We do an MR for prognostic purposes for MS, looking for demyelinating white matter lesions. If it's an atypical case, we're going to do the tests that Pam alluded to in terms of inflammatory or infectious etiologies, syphilis, serology, sarcoid in the United States, ESR, white count, ANA, chest x-ray, and you may or may not perform a lumbar puncture, an MR of the spine, and the NMO antibody in a patient who has bilateral optic neuropathy. This right here is my workup for NMO and the DeVick variant. There is no equivalent ONTT in childhood, however. So the workup is not known, okay? But most people are working them up because of the presentation, and the presentation looks like this. It tends to be bilateral, it tends to have a swollen disc, they have bad vision loss, and it may be associated with the other neurologic findings of acute disseminated encephalomyelitis, with the key being the encephalopathy component, mental status change, confusion. Those things are going to prompt workup for a kid in the United States of America, and probably here too. And so we often do all these tests, and we come up with a big goose egg, 0, and we blame it on post-infectious or post-vaccination related optic neuropathy, or if their head is full of white matter lesions, especially if they look like the lesions that Pam described, big, confluent, especially basal ganglia and thalami, we're going to label them ADEM. Again, not evidence-based, okay? In the ONTT, I told you IV steroids, speeds rate of recovery, oral steroids, increase new attacks, I don't give it. And then I would consider immunomodulatory therapy based on CHAMPS, ETOMS, and the other studies that have been done for demyelinating disease. In children, we do not have an equivalent to CHAMPS and ETOMS, but many authors, including myself, will treat these patients with intravenous steroids, especially if their head is full of ADEM lesions. I don't know whether it makes a difference or not, but I do. The steroid course is a little bit different. As Pam alluded to, if you taper too quickly, you often get a relapse, and that's really important to avoid because ADEM, the classic, is monophasic, a one-time deal, as we say. But if you taper the steroids too quickly, they'll get a relapse, and then they'll end up with this label, relapsing ADEM, rule out multiple sclerosis, when all it was a too fast a taper of the steroid led to a relapse. And we don't want to be labeling this kid with multiple sclerosis because then they're going to get the immunomodulatory therapy. And so it's really a very dangerous thing to let the person relapse. They are less likely to develop multiple sclerosis, but the risk is not 0. This is a different study from Mayo Clinic, bigger study with a longer follow-up. In this case, a mean follow-up of 20 years. In the life table analysis of this much longer study, only 13% of the cohort with optic neuritis went on to progress to clinically or laboratory-supported definite multiple sclerosis at year 10. This is different than the optic neuritis treatment trial data in adults because the other 87% of the cohort probably had post-infectious or post-vaccination monophasic optic neuritis or ADEM, and that's different than MS. So this ADEM is the key differentiating thing you need to know about. It's acute and monophasic monophasic, remember, a relapse on the steroid taper is not the same thing as a relapse in MS. Post-infectious Pax vaccination, mean age 6 to 8 years younger, 40 to 50% of the patients are febrile. In my practice, if they have fever, I would be thinking a lot less about multiple sclerosis, even though some of these patients with monophasic looks like ADEM, as Pam alluded to, are down the road on multiple sclerosis, and yet they had fever at onset. Why is that? Because the trigger is the same. The post-infectious trigger was the same. For MS in one circumstance, and the other circumstance, a monophasic demyelinating event. I don't like nausea, vomiting, malaise, and stiff neck for demyelinating disease, but again, maybe this is the first attack of demyelinating disease. Just to summarize the things that she showed you on the clinical and radiographic differences between ADEM and MS. ADEM has more ataxia, hemiparesis, and the encephalopathy signs, confusion, and changes in mental status. ADEM lesions are bigger. They involve gray matter. They're bilateral, chunky lesions that are all gadolinium enhancing on the same age. And the thing I look for is that thalamic and basal ganglia involvement, which can occur in demyelinating disease, but is much more common in my experience with ADEM. In addition, there's a hemorrhagic form, which I just mentioned, for completeness. So, what's my approach? If they have typical childhood optic neuritis, I'm going to do that MR head orbit with contrast material. I'm going to consider a spine MR if they're symptomatic or if I'm worried about the DeVick variant. We're going to do a lumbar puncture, and my cutoff is kind of 50 cells, but some people's cutoff is different. If you got 100 cells, it's hard to convince me that's demyelinating disease. That's much more likely to be a post-infectious ADEM. And we're going to exclude infectious etiologies. In the United States, a PCR for HSV is going to be done on our patients who have CSF abnormalities and bilateral optic neuropathy, and they often are being treated empirically in the U.S. with acyclovir. I give them intravenous steroids once I've made sure it's not infectious, and I kind of dose it up to the dose based on the kid's weight, because we can't just give everybody a gram a day like we do in adults, up to a gram a day at 30 mg per kg for 5 days, and then an oral taper. So it's a little different than the optic neuritis treatment trial because the dose is different, it's based on weight, and the duration's different because I'm trying to get those white matter lesions in the brain to go down. And you've got to follow the patient just like an adult, because some of these patients are going to develop multiple sclerosis, and we do a follow-up MR scan in ADEM to make sure the lesions are regressing, and also we're looking for dissemination radiographically in time to support the diagnosis of childhood MS. So in summary, the key differences between childhood and adult optic neuritis: more bilateral, more disc edema, and more severe vision loss in the childhood form of optic neuritis. It looks like an atypical optic neuritis in adult, but that's the typical prototype for childhood optic neuritis. It's less likely to be multiple sclerosis and more likely to be either isolated post-infectious optic neuritis or acute disseminated encephalomyelitis, ADEM, a monophasic condition that can relapse or become multiple sclerosis. I have a different approach to the optic neuritis in childhood because parents push me normally to do all these things, but also because we don't have a good evidence base and some of the kids are sick. That means they get the full court press, MRI scan, lumbar puncture labs, and treatment with intravenous steroids, and exclude infectious etiologies, especially herpes, because that's treatable with acyclovir. There is a limited evidence base because there is no childhood equivalent of the optic neuritis treatment trial for the ONTT in adults. And I've described my approach, but you need to individualize this to your individual patients in your part of the world. And I thank you for your time and attention.
Thanks. Thank you, Andy.